Hello, my dearest students. This is Dr. Rohith Daniel, your orthopedics faculty from DocTutorials. So we have finally finished our NEET exam, right? Oh, what a 2024 NEET exam we had. Probably the most frustrating of the NEET exams we had in the last several years. With all those preponements and postponements, obviously it has taken a big mental toll on many of my students. Anyway, finally, you have all completed it. First of all, a big congratulations to all of you. Very well done. It's not easy to go through all these upheavals like this. Anyway, well done for all of you. So if you look at the orthopedics exam, the questions were a little bit difficult when you compare it with the last few years. It's not that the questions are very difficult, but if you compare it with the last few years, the questions that were asked from orthopedics over the last 2-3 years have been very, very easy. In fact, the questions were very superficial, and if you had a superficial knowledge of orthopedics and if you had learned few one-liners, I was sure that you could have got at least around 80 or 90% marks in orthopedics. But this time that is not the case. Many of the questions that were asked were a little bit in an in-depth fashion. Unless you know these concepts from a very basic level, it would have been difficult to answer these questions. So I would say that these were a little bit difficult, but thankfully all these questions had come from our previous year topics. There were no new areas of questioning as such. All were from previous year questions. Okay. So let's discuss these questions one by one. We'll start with the forenoon session, the paper one. All right. So we had 7 questions from the paper one, and I felt that the questions in the first paper was a little bit more difficult than the second paper. Anyway, let's see the questions. Unfortunately, we'll have to start with the very controversial questions. Many of the students were regularly asking me, sir, what is the answer for this question? See, this is a 8-year-old male who presents with the swelling of the right thigh, and he has intermittent fever, ESR and other inflammatory markers are elevated. His X-ray is given below. What is the diagnosis? Okay. So you have 4 options: osteosarcoma, Ewing sarcoma, osteomyelitis, and chondrosarcoma. First of all, let's look at the X-ray. What do you see here? This is obviously the femur, and where is the tumor? The tumor is in the diaphysis. So you have a diaphyseal tumor. And what are the features you see here? First of all, you can see this kind of periosteal reaction like this. This is what we call as the sunburst periosteal reaction. And if you look closely, most students even told me that there was a hint of Codman's triangle. You can see the elevated periosteum with triangular formation of bone underneath. This is your Codman's triangle. Codman's triangle. Okay. Now let's look at the options. So this is an 18-year-old boy. So obviously it cannot be chondrosarcoma. Why? Chondrosarcoma will occur only after 50 years of age. So obviously this is not chondrosarcoma. Can it be osteomyelitis? That is a very good option. Why? Because there are symptoms of inflammation. Inflammatory markers, ESR and all are elevated, isn't it? So that is a possibility. But the periosteal reaction, they are malignant periosteal reactions, isn't it? So obviously you can rule out osteomyelitis. Now there are 2 confusing options, osteosarcoma and Ewing sarcoma. Now how to differentiate? If you look at osteosarcoma, the age is good. The most common malignant bone tumor at 18 years of age is osteosarcoma. But will there be inflammation? Will there be fever and inflammatory markers being elevated? That is very, very rare in osteosarcoma. This more points towards Ewing sarcoma. And moreover, the diaphyseal presence of the tumor is also pointing more towards Ewing sarcoma. And Ewing sarcoma can also present with sometimes present with sunburst periosteal reactions and Codman's triangle. Even though the classical periosteal reaction that we say is what? The classical periosteal reaction in Ewing sarcoma is onion peel periosteal reaction, but that may not be the case always. Okay. So rarely you can get these kinds of periosteal reactions. So I would say that the best answer to this question would be Ewing sarcoma. But there is a but. If in the X-ray, the tumor was from the metaphysis, then you could have blindly written the answer as osteosarcoma. Or if in the question there were no inflammatory changes, or if there was no fever and elevated ESR, again you could have gone with osteosarcoma. But with all these clues given in the question, I think the best answer would be choose Ewing sarcoma. All right. Now let's look at the next question. A 6-year-old child presents with history of fall and pain in her elbow. She has sustained a fracture and the X-ray is given below. Classify the fracture. Okay, usually in orthopedics, they will give an X-ray and they will ask you to diagnose the condition. But this time, they have gone in depth. They have asked for the classification, isn't it? So what is the X-ray? This is an X-ray of the elbow. And what do you see here? This is the humerus. And this is the ulna, this is the radius. Now you see a fracture. Where is the fracture? The fracture is involving the humerus in the supracondylar region, isn't it? So this is your classical supracondylar fracture of humerus, which is very commonly seen in children. In fact, this is the most common elbow fracture in children. Now, what is the classification? I've taught you this many times. This is your Gartland classification that you use here, isn't it? In Salter-Harris classification is a very non-specific classification for physeal injuries. We use that for children, but with respect to supracondylar fracture, you don't have to worry about Salter-Harris. It is Gartland classification. So what is Gartland classification? Very easy classification. You have 3 types. Type 1 is an undisplaced fracture. Type 2 is a partially displaced fracture. And type 3 is a complete displaced fracture like this. So look at the X-ray. It is a completely displaced fracture. So obviously this is Gartland type 3. That is our answer. Okay. Now let's look at the next question. This is a image of an amputation. Identify the amputation shown in the image below. So you can see that there is a sectioning of the limb and the wound has been left open. It is not closed. This kind of amputation is what we call as a guillotine amputation. Guillotine amputation is usually done in the presence of severe infections. Okay. And you can clearly see that in the cut end of the limb, you can see the tibia here. And you can also see the fibula. All the students told me that tibia and fibula were clearly visible. So obviously this is a below knee amputation. This is a reasonably easy, very easy question. Let's look at the next question. A 35-year-old male had sustained fracture of the 5th metatarsal and was treated using the cast shown in the image. How long should the cast be applied? So again, the question is going in an in-depth fashion. Usually, you get an X-ray of 5th metatarsal fracture and the question would be, how do you treat it? And you answer it as a BK cast. But now they are asking for the duration. The correct answer here is 6 to 8 weeks. Most lower limb fractures require around 6 to 8 weeks for proper healing. The answer is 6 to 8 weeks. Next question. A man injures his back in an RTA. His X-ray is given below. What is the diagnosis? Okay. So is it a flexion distraction injury, wedge compression fracture, burst fracture, or a flexion compression injury? So this again is an interesting question because we had 2 opinions from students. Some students told me that, sir, there was a wedging of the vertebra and probably this was a wedge compression fracture. But most students told me that no, sir, there was no wedging, but there was a horizontal fracture going through the vertebra. A horizontal fracture line like this, going across the vertebra from anterior to posterior like this. And this is what we call as a chance fracture. And the mechanism of chance fracture is flexion distraction. So the correct answer to this question is flexion distraction injury. Chance fracture used to be asked very often around 5 years back. Now the question is making a reappearance here. Anyway, what is this chance fracture? It is a seat belt injury that occurs during a front end collision. So I'll tell you a story. So someone is riding a car. He's going quite a bit fast and he loses control of his car and hits a tree. What will happen? His car will suddenly come to a standstill. But what about his body? His body is in inertia of motion. So his body is thrown forwards, isn't it? Thrown forwards. But there is a restraint around his abdomen. What is that? That is your seat belt, isn't it? And because of the seat belt, the entire body gets folded like this. It will be folded on top of each other. It will be folded on top of each other, and the fulcrum would be the spine here. And because of this, there will be a flexion distraction injury, and you get this characteristic horizontal fracture through the vertebra. You get a horizontal fracture like this, involving the anterior, middle, and the posterior columns of the vertebra. So this is a very unstable fracture, and often will have an associated spinal cord injury as well, and this is usually treated surgically. So remember, chance fracture, it's a seat belt fracture, also called as a jackknife fracture. The mechanism is flexion distraction. Okay, so that is our answer. Now let's look at the next question. A 25-year-old male presents with back pain that radiates to his right lower limb. His MRA shows intervertebral disc prolapse, IVDP L3, L4. Which nerve root will be compressed? Is it L2, L3, L4 or L5? Again, we have discussed this so many times. What is the answer here? Whenever there is an IVDP at a particular level, the traversing nerve root will get compressed. And if it is L3, L4, the second part, that is L4, will be the nerve root that will be involved. Okay. So what is this traversing nerve root? I'll show you a picture and explain. So this is the coronal section of the spinal column. And you can see that this is the L3 vertebra, this is L4, and this is L5. So this is something that you must pay attention. Please listen to me carefully here. L3, L4, and L5. This could be any vertebra, L1, L2, L3. This is just for example, I am taking L3, L4, L5. And what do you see between L3 and L4? This is your L3, L4 intervertebral disc. And this is your L4, L5 intervertebral disc. Now, near to every intervertebral disc, there are two nerve roots. What are they? One is called a exiting nerve root that goes like this. And this is the exiting nerve root at the level of L4, L5. And there is a traversing nerve root that goes like this. It crosses that disc and goes below it and goes out through the foramen there. So that is called the traversing nerve root. So you have exiting nerve root and traversing nerve root. Remember that more than 95% of the time, it is a traversing nerve root that gets compressed. So if the disc is L4, L5, the traversing nerve root is L5, the exiting nerve root is L4. This is universal dictum. Okay. So you can write this in alphabetical order. E exiting is L4 and T traversing will come second. That is L5. In L3, L5 disc level, L3 is the exiting nerve root. L4 is the traversing nerve root. What about L1, L2? L1 will be the exiting nerve root and L2 will be the traversing nerve root. Okay. Now, the thing you must remember is that in 95% of the cases, it is a traversing nerve root that gets compressed. You can remember it like this. Traversing nerve root will get trapped. Traversing nerve roots will get trapped. Exiting nerve root will escape. Okay, this is what happens in 95% of the cases. So practically speaking, in all IVDP, if say L1, L2 disc prolapses, it is L2 nerve root that gets compressed. If L2, L3 gets prolapsed, L3 will get compressed. If L3, L4 disc prolapses, it will be L4 that gets compressed. So let's go back to the question. So this is L3, L4 disc that has prolapsed. So it will be L4 that gets compressed. Now let's look at the final orthopedic questions from the first paper. Identify the implant used in X-ray, used from the X-ray given below. I think this is a very straightforward question. Most of the students have gotten this correct. You can see that this is an X-ray of the hip joint. There is probably a fracture somewhere here which has been fixed using this implant. This is the dynamic hip screw. Dynamic hip screw, also famously called as the DHS. Okay. So this is the dynamic hip screw. So what is this proximal femoral nail? This is the proximal femoral nail, which is again used for treating intertrochanteric fractures. Remember, dynamic hip screw is also used for treating intertrochanteric fractures. Okay, intertrochanteric fractures. And the other device that we use for fixing intertrochanteric fracture is proximal femoral nail. Then what about DCS or dynamic condylar screw? It is used for fixing distal femur fractures. And what about this? This is a very, very famous plate, isn't it? This is dynamic compression plate or DCP. This is the most commonly used implant for fixing. So we use this for fixing radius fractures, ulnar fractures, humerus fractures, femur fractures. This is the most ubiquitous plate that we use for surgery. Okay. So these were the 7 questions that had come for the paper 1. I think this was a little bit tough. Don't worry. So I think this paper was a little bit more tough than the second paper. I think don't worry. We have normalization going on. Even if you had made a few mistakes, it's not going to matter anyhow. So make sure that next time when you learn, try and learn the topics in a little bit more depth in orthopedics so that you won't miss any of these questions. Okay. All right. We have finished the discussion of the first paper. Now we will discuss the second paper from the NEET PG 2024 orthopedics questions. So here we had around 9 or 10 questions, and I would have to say that this paper, even though had more questions in orthopedics, was a little bit more easier than the first paper. Okay, let's discuss. What is the type of fracture healing you can expect in a fracture treated in a manner shown in the X-ray? Very nice question from the basics itself. So what do you see here? You can see that there is a fracture of the femur that has been beautifully fixed using a plate and screw, isn't it? You have plate and screw fixation of the fracture femur. The question is, what kind of healing will you expect? So then you need to know that there are 2 kinds of healing, isn't it? Your primary healing and secondary healing. You don't have to worry about creeping substitution and intramembranous ossification. For most common fractures, there are 2 kinds of healing, primary healing and secondary healing. Okay, what is the difference? Primary healing is a type of direct healing where you have connection or fusion of 2 bones without any callus formation. So direct healing without callus formation is called primary healing, and it is seen in plate fixation. What is secondary healing? It is indirect healing with the formation of large amounts of callus. And this is usually seen in intramedullary nail fixation and POP application. Okay. So you can remember primary healing like fixing a toy or something with a quick fix. So you have a broken pen, then you can just fix the edges together with a quick fix or super glue or something. There is there are no protruding things outside. So that is your primary healing. In secondary healing, you can remember it like fixing a leaking pipe with seal on the outside. So you have a lot of callus-like thing on the outside. That is secondary healing. Okay. So whenever you do plate fixation, there is a rigid fixation because of which you get primary healing. So you can remember it like this. P is for plate fixation and P is for primary healing. Okay. And secondary healing is for intramedullary nailing as well as for POP application. I'll show beautiful x-rays here. These are 2 cases of tibia fractures treated differently. Okay. Here we have used plating and here we have used intramedullary nailing. You can see that both these fractures are completely united. Here you can see callus, isn't it? So because it is callus, this is secondary healing. What about here? The fracture line was somewhere here. You cannot even see it properly because the fracture is beautifully healed by primary healing. Okay, there is no callus here. No callus here. So remember, plate fixation, there won't be no callus. So this is primary. In intramedullary nailing, there will be abundant callus, and this is secondary healing. Okay, remember primary healing, P for primary healing and plate fixation. So what is the answer here? Plate fixation. Okay, so that is the correct answer. Next question, a very, very easy question I have to say. This has been asked multiple times. Which of the following fractures can cause a deformity as shown in the image? What is this? This is your classical gunstock deformity, isn't it? This is your gunstock deformity, also called the cubitus varus deformity, which is seen in the malunion of supracondylar fractures of humerus, isn't it? Seen in malunion supracondylar fractures of humerus. That is the correct answer. And what deformity will you see in lateral condyle humerus fracture non-unions? You get cubitus valgus. Cubitus valgus, which is just the opposite deformity of cubitus varus. Okay, I think this is a very straightforward question. I think most of you have got this correct. Next question. A 18-year-old male presented to the OPD with history of injury during sporting activity. He complains of pain in his knee. X-ray was taken, which was normal. The doctor performs the test shown in the image to rule out any ligament injuries. Identify the test. So whenever there is a sports injury, the first thing that the orthopedician does is obviously to take what? X-ray, isn't it? We have to rule out fractures. Most of the time there won't be any fractures, but there will be huge swelling. There will be signs of inflammation. The patient won't be able to walk. So we have to think in terms of ligament injury or a meniscus injury if the knee is injured. Okay. And the most important ligament injury that you have to rule out is what? Anterior cruciate ligament. Anterior cruciate ligament is probably the most important ligament in our knee joint, and you have to test it by clinical examination. And what test do you see here? This is the classical Lachman or the Lachman test. Okay, Lachman test. So for ACL, there are two important tests. One is your anterior troy test and Lachman test. How do you differentiate these two? This is very easy. You can just look at the angle of knee bending. Okay, here you can see that the knee is bent to 90 degrees. If the knee is bent to 90 degrees and the doctor is applying an anterior translation to see if the ACL is lax, this test is called the anterior drawer test. This is the anterior drawer test. But if the patient's knee is flexed to just 30 degrees, so if you look at this, this is 30 degrees. If the knee is bent to 30 degrees and you do an anterior drawer like test, you call it a Lachman test, which is better test. Always remember Lachman is the better test. Why? One, it is less painful. Two, it is more sensitive and specific. So always do Lachman. Okay, Lachman test in an acute setting. So that is our answer here. So shall we move on to the next question? A child presents with a tumor of the diaphysis of femur. Biopsy showed sheets of round blue cells. Which of the following genetic mutations could have caused this? So I've told you, if there is a tumor of the diaphysis, there are two important tumors you have to keep in mind. What are those? One is osteoid osteoma and the other is Ewing sarcoma, isn't it? Ewing sarcoma. These are the two tumors that you have to always keep in mind. Osteoid osteoma is benign and Ewing sarcoma is highly malignant. And which tumor has round blue cells in biopsy? It is your classical Ewing sarcoma, isn't it? Ewing sarcoma produces the classical round blue cells. If you take a microscopy, everywhere there will be round blue cells and some pseudorosettes. That's all. This is the classical presentation of Ewing sarcoma. And what mutation causes Ewing sarcoma? It is translocation 1122. 1122. Very, very important topic. So you can remember it like this. 1122 is for Ewing. Okay. 11E and Ewing is also E. Where do you or what does translocation X18 cause? It causes synovial sarcoma. This is also an important MCQ. What happens when there is an X gene mutation, EXG mutation? You have hereditary multiple exostosis or diaphyseal eclasis where the body is covered with osteochondromas. And what about GS alpha mutation? It is seen in fibrous dysplasia. Fibrous dysplasia. Okay. So remember, this is a very, very important topic. And similar questions have been asked several times in INICT also before. Very, very important topics there. the genetic mutations causing various bone tumors. Okay. Next question. I think this is a very, very easy question for you. Injury to which part of bone can result in inhibition of linear growth of bone? And tell me the answer here. Which is the structure that is responsible for the linear growth of bone? It is the growth plate or the physis, isn't it? So when the physis is injured, obviously there will be growth arrest and sometimes even angular deformities. Okay. Moving on to the next question. A patient presents with sensory loss over the lateral 3.5 palm and fingers with inability to flex the IP joint of thumb. What could be the possible injury? This is a very, very interesting question. Is it a high radial nerve injury, high median nerve injury, carpal tunnel syndrome, or ulnar nerve injury? Let's see. Okay. So there is sensory loss over the lateral 3.5 parts of palm and fingers. Okay. So which nerve is responsible for the sensory supply here? It is median nerve, isn't it? It is median nerve. What about flexion of IP joint of thumb? Which muscle is responsible for flexing the IP joint of thumb? Can you tell me? This movement is done by flexor pollicis longus, which is again supplied by your median nerve. Okay. So median nerve is responsible for the sensory supply as well as the motor supply of the flexor pollicis longus. Okay. Now, we know that there are four options here, and we also know that it is not high radial nerve injury and it is also not ulnar nerve injury because it has something to do with median nerve, isn't it? Now the question is it high median nerve injury or carpal tunnel syndrome? What is carpal tunnel syndrome? Again, it is a compression neuropathy or injury to the median nerve, but here the injury is at the level of the wrist, isn't it? Under the flexor retinaculum. That is where the median nerve compression occurs. So carpal tunnel syndrome is actually an example of what? A low median nerve injury. Basically, the examiner wants you to tell him whether this finding will be seen in a low or a high median nerve injury. Okay. For that, you need to look at this, the branches of median nerve. Okay. So if you look at the branches of median nerve, most of the branches are sent off at the level of the elbow. You have branched pronated teres, FCR, palmaris longus, flexor digitorum superficialis. Then it gives off a deep motor branch, which is called the anterior introitious nerve, which is very, very important. Anterior introitious nerve is the deep motor branch of median nerve, which supplies flexor pollicis longus, flexor digitorum profundus, lateral half, and pronator quadratus. Okay. Then it descends down, and at the level of the wrist, after the level of the wrist, it will supply thenar muscles, first and second lumbricals, and also gives off the cutaneous branches. Now, what happens in carpal tunnel syndrome? In carpal tunnel syndrome, the level of block is where? The level of block is at the level of the wrist. Okay. That is what happens in CTS. So what will happen? There will be sensory problems. There will be wasting of the thenar muscles. But will the flexor pollicis longus be involved? No. Why? FPL has been supplied much above, isn't it? Through the anterior introitious nerve, which has been sent off at the level of the elbow. Obviously, that is not going to get compressed by the flexor retinaculum. So, FPL will be spared in carpal tunnel syndrome or any injuries around the level of the wrist. So, low median nerve injury, FPL will be spared. In high median nerve injury, that is an injury to the median nerve at the level of the elbow, that is where you get involvement of the FPL. Okay. So what is the answer to this question? It is high median nerve injury. Understood? Okay. Now let's move on to the next question. A patient presents after injury with a positive O sign. Positive O sign. The paralysis of which muscle causes the test to be positive on the index finger? They are given OK sign or O sign, and the question was either relating to the thumb or the index finger. But I think that it could be related to the index finger because already there has been another question where FPL involvement was asked. So probably here index finger was asked. Anyway, we had four options: flexor pollicis brevis, abductor pollicis brevis, opponent's pollicis, or flexor digitorum profundus lateral half. Now, to analyze this question, you need to know what O sign is. What is O sign or OK sign? O or OK sign, sometimes called as the circle sign or the Kilo-Nevin sign. What is this? This is a test for anterior introitious nerve. What is anterior introitious nerve? It is the deep motor branch of median nerve. We already learned that, isn't it? It supplies three muscles: flexor pollicis longus, flexor digitorum profundus, lateral half. What else? Pronator quadratus. For the moment, we'll forget pronator quadratus. We'll focus on flexor pollicis longus and FDP lateral half. Okay. So what is the function of FPL? This, the flexion of IP joint of thumb. What is the function of FDP lateral half? It is the flexion of DIP of index finger. Okay. So if you want to make a beautiful O like this, if you ask the patient to make a beautiful O like this, if the patient has to do like this, the flexion of the IP joint of thumb, that is FPL, must be working. Similar, the flexion of the DIP joint of the index finger or the FDP lateral half has to be working. So if both these muscles are paralyzed, which occurs in anterior introitious nerve palsy, if you ask the patient to do like this, patient won't be able to sustain this posture. He will go like this because this flexions are not possible. So instead of keeping like this, he will go like this. So that is your okay sign. Okay. So the question is, patient has okay sign. Which muscle is paralyzed or is involved in the index finger? The answer is flexor digitorum profundus lateral half. Next question. A 55-year-old female presented with back pain for the last 6 months. The CT image is given below. What is the diagnosis? Okay. So this is a very, very straightforward question. Most of the students told me that a very clear subluxation of the vertebrae. As you see here, there is subluxation of this vertebra when compared to the underlying vertebra, isn't it? The subluxation of one vertebra on top of the other is what we call as spondylolisthesis. That is the answer here. Spondylolisthesis. Let's look at the other options as well. What would be the finding in Paget's disease? You would have the picture frame vertebra, isn't it? Picture frame vertebra. What about osteoporosis? We have the classical codfish vertebra. Codfish vertebra, also known as Lincoln log vertebrae or biconcave vertebra. What about renal osteodystrophy? We have the super classical Rugger Jersey spine. I think for this question, the correct answer would be spondylolisthesis. Okay, moving on. Identify the part of the bone shown in the X-ray. Again, a very, very controversial question. Some students told me that there was a fracture that was marked. Some students told me that there were no fractures. Some told me that the arrow or the pointer was pointing towards the medial femoral condyle. Some said that it was pointing towards the tibial tuberosity. Again, the correct answer would depend upon the X-ray image. Okay, so I'll just tell you, if the X-ray was like this and the marking was here, then this is medial femoral condyle. Why do I say that it's medial femoral condyle? Because you see the fibula here, isn't it? This is the fibula and the fibula would be lateral. So this would be medial. So that is the medial femoral condyle. However, if the arrow was here, that would be your tibial tuberosity. Tibial tuberosity. What about Gerdy's tubercle? Gerdy's tubercle is somewhere here. Okay. So I think the answer is either medial femoral condyle or the tibial tuberosity. That was the overwhelming response that I got. Anyway, for this discussion purposes, I will be marking medial femoral condyle as the answer, but it could also be tibial tuberosity depending upon the on the area where the pointer was kept. Okay, all right. A patient suffers inversion injury to his ankle. Which structure is most likely to get injured? Tibialis anterior tendon, tibialis posterior tendon, extensor hallucis longus, or the peroneus longus tendon, or the anterior tibiofibular ligament. Okay, so I'm not sure of the all the options that were given. The probable answer would either be a peroneus injury or a anterior tibiofibular ligament injury. So whenever there is an inversion injury, what is inversion? Where the foot will go inward like this. And this is the most common mechanism of injury in the ankle. Inversion injury. Whenever you are climbing a step, climbing down step, suddenly you might slip a step. you may miss a step and suddenly your foot will go in for inversion. That is the most common type of injury in the ankle. And the most common structure to be injured in an inversion injury is what? That is your ATFL. ATFL is the most common structure, that is anterior tibiofibular ligament. In fact, this is the most common ligament to be injured in the whole body. It is said that every human being will get an ATFL injury at least once in their lifetime. That is how common ATFL injury is. So if that was in the option, then that will be the answer. If that was not there in the option, then one of the structures on the lateral side of the foot. Most commonly, it would be the peroneus longus or the tendon that would be injured. Okay, so that is our answer. Okay, so those were the questions, recall questions from orthopedics. I wish you all the very best for the upcoming results. Thank you.